Assalamu alaikum wa rahmatullahi wa barakatuh. In this tutorial video, we will talk about RH system in general and we will explain the RH phenotyping. So we will talk about RH system in general, the properties of RH antibodies and RH antigens. Also, we will talk about D variants. Then we will move and explain the antigen-antibody reactions both in vivo and in vitro. We will also discuss serological RH phenotyping. We will discuss and interpret results together, and we will take a number of examples. RH system is the second important system in transfusion. It's come after the ABO system. So incompatibility between patient and donors can cause severe hemolytic transfusion reaction. Also, it can cause a hemolytic disease of newborn, and we will explain both of them in this video. This system is controlled by two genes. So it's controlled by the RHD gene. Also, it's controlled by RHCE gene. These two genes are homologous genes, both located at chromosome number 1. So unlike other systems, the most of red blood cell systems are controlled by one gene. However, this is RH system is one of the exceptions. So it's controlled by two genes rather than one. There are a large number of antigens in the system, and according to ISBT, there are 55 antigens belong to this system, and the most important one is D, and also there are another 4 important antigens, which are big C, little c, big E, and little e. These are the 5 principles. These antigens are present on RHD protein. Also, some of them present on the RHCE protein, which located on the red cell membrane. RH antigens is different than ABO antigen. ABO antigen present not only on red blood cells, but in many other cells. It's present all ABO antigens present also in soluble form in plasma, for example. Also, they present on many tissues. However, RH antigens present only on red blood cell. So we expand the red blood cell membrane several times. It's 12 times or more than that. So, and RHCE protein is also have very similar structure to the RH protein. So again, expand the red cell membrane 12 times. So people with D antigen or positive people, they have the protein. However, D negative people, they lack the whole protein. So we don't find RHD protein on their cell membrane. Most of D positive people have normal D. However, some people have a variance D. So some people have weak D and other people have partial D. The difference between weak D and normal D is a quantitative difference. So the number of D protein on their red blood cell is much lower than people with normal D type. So the main difference is the number of copies. So people with weak D, sometimes we type them first as negative, but when we do a special test, which is called weak D test, the result will be detected as positive, and we will explain the weak D test. So people with weak D either donors or patient are considered as the positive people. However, partial D, people with a partial D, they are missing some epitopes present normally on the protein. So partial D, because they are missing some people with partial D, because they're missing some epitopes of normal D, when they received normal D cells, they may sensitize and produce antibody against these missing epitopes. So for this reason, patient with partial D, so recipients or patient should be considered as the, if they are partial D, should be considered as negative, because they have or they must received the negative blood. However, donors with partial D should be considered as positive people, should be labeled their unit as positive. However, as we said, the patient should be labeled as negative because they may sensitized when they received normal D blood. However, both of them, weak D and partial D, they are very, very small proportion of the positive people. Let's discuss now the Rh antibodies. So, the class of Rh antibodies are from IgG type, so it's monomer. And it's immunogenic antibodies. What does this mean? So immunogenic antibodies, that means they are not naturally occurring. They produced only when the person exposed to foreign red blood cell antigen carry the antigen. So in transfusion, or so patient may expose to these foreign cells in transfusion, transplantation, also in pregnancy. So unlike ABO antibodies, which are called naturally occurring antibody, so in case of ABO antibodies, we will find these antibodies even in people which are not exposed to foreign red blood cell. However, here it's need to be exposed. Properties of these antibodies, they are incomplete. They are IgG type, so they are incomplete. Most of the IgG type are incomplete antibodies, so they cannot cause direct agglutination. It's need enhancement media, such as using Coombs reagent. They are warm antibodies, so they work at 37. So anti-D, anti-C, anti-E, for example, they work at warm temperature, so they are not working at room temperature. So this is the properties of the antibody. Antigen-antibody reactions in vivo. So in case of incompatibility between patient and donor, that can cause transfusion reaction. So in first exposure, so if the patient exposed to foreign red blood cell with the antigen for the first time, patient may sensitized and the immune system will produce for example, anti-D. So production of these antibody, as we discussed in another video, is take time. So it sometimes takes several weeks or sometimes months to produce antibodies. So in first exposure, the patient will not affected. Usually, or in general, the patient will not affected. I mean by not affected, it will not expect to detect hemolytic transfusion reaction. The only side effect or adverse effect will happen is the sensitization event. So the patient will produce anti-D if he or she responds to the donor cells. So the donor cells will survive, but in second exposure, because now the body is ready and the antibody is already present in the circulation, and also there are memory cells, so the antibodies in the circulation, and also there are memory cells which are responsible to produce additional amount of antibody. So in second exposure, the, uh, the antibody will sensitize the donor cells. So this is the RBC of the donor. So if we give the patient positive blood, the antibody will bind, the patient cell antibody will bind to donor cells, and it will sensitize the cell. So the cell will be sensitized with the antibody. The sensitized cells will be passed during circulation and the spleen. So in spleen, there are, as we discussed in other video, there are macrophages. So the macrophages will remove the sensitized cells from the circulation, which cause extravascular hemolysis. So extravascular hemolysis, and that cause hemolytic transfusion reaction. So we will notice that hemoglobin is dropped again. So when we do that test for this patient, we must expect it to have positive result. So in case of hemolytic disease of newborn, the vast majority of the severe cases of hemolytic disease of newborn is associated with anti-D, is associated with anti-D. So if the mother is negative, so this is the mother, so if she is negative, okay, and have she's pregnant and she have a negative baby, sorry, positive baby, in first pregnancy we don't expect to have hemolytic disease for newborn, because as we said before, in first exposure the immune system will take time to respond to positive blood and produce antibody. So usually first pregnancy is not affected that much. However, in second pregnancy, if the baby is also positive, so we expect the baby to have hemolytic disease of a newborn, because the antibody is already formed under a memory cell. So these antibody will go in the baby circulation and cause hemolytic disease for newborn. So will cause anemia, and the anemia may be very severe, leading to severe cases of hemolytic disease of newborn. So in order to avoid these complications, we usually try to protect a woman at childbearing age from being sensitized. So try to provide them with compatible blood as much as we can. Also, at the beginning of pregnancy, we have to give a pregnant woman Rogam if she is negative. So because we want to protect her from being sensitized. So let's move now and talk about reaction in vitro now. So usually in vitro, we try to detect presence of the antigen. So we are looking for the antigens. We are not looking for antibody in this step. So in Rh phenotyping, we usually focus on the antigen, unlike the ABO typing. So if you remember in ABO typing, in previous video, we talked about ABO typing. So we have to do direct test and indirect test, but here we just focus on looking to the antigens. So in order to detect antigen, we have to add anti-serum. So in this case, we will add anti-D if we are looking for the antigen, or anti-big C, little c, big E, little a if we do extend Rh phenotyping. The type of anti-sera usually used is from IgM type. So it's from cell line, it's IgM type. So because it's IgM, this is considered as advantage for us, because IgM, as you know, is cold antibody, so it work very good at room temperature, and because it's IgM, it can cause direct agglutination, so there are no need to use enhancement media. So, for example, there are no need to use Combs reagent. It can cause direct agglutination. So, because we are looking for antigen, the sample we have to use is the patient red blood cell. So, we will add patient red blood cells, use patient red blood cells, and add an anti-sera. Sorry, away from each other. So this is the patient red cells. So we have just to add anti-sera, which is pentamer, so it can cause direct agglutination. So let's have now explain in details the RH phenotyping, so surgical test. So as we said, we're usually looking for antigen. So when we do D-typing, we have to run control. We have to run control with it, and the control reagent contains a very similar ingredients of anti-D, anti-sera. However, the only difference between anti-D vial and control vial is the present that the control miss the antibody itself. So it contains everything like preservatives and everything except an antibody. So because it doesn't have antibody, it must be negative. It must give negative result, isn't it? However, if it's give positive result, that means there are autoagglutination. So the result is invalid because there are no antibodies. So why it give positive? That means there are autoagglutination happen. So maybe patient cells, for example, is that positive. So when we type patient or donors, we have to be sure 100% that our result is valid. So in this case, that means our result is not valid. So it should give negative result. So let's have this example together. Here, so if we type patient, so let's give, for example, +4, and here +3, +4, here 0, and here +3, for example. So the phenotype of this patient is D, big C, little c, and small e. So this is the result. So a very important point here, the big C and little c are antithetical antigens. One of them at least must be present. And big E and little e are antithetical. So must, again, one of them at least must be present. So this is an example. So the phenotype of this donors or patient is that. Let's have another example. So here, let's imagine that this patient is, for example, here is 0, and here 0 negative. So here also 0. Here, let's say it's +3. So and here 0, and here +4, for example. So the phenotype of this patient is small c, small e. So this is the phenotype, and sometimes we write them like this. So a little d, and the patient is missing the D protein. So this is an example. But if we have this result, so we can notice here the donors in this example is negative. So we should not stop here. Because the donor here is looked at as negative, we must do weak D test to be sure that this patient is really negative. It's not just weak D, because as we said before, weak D means lower number of copies on red blood, lower number of D copies on red blood cells. So the patient may type as negative, but actually it's positive. But because of this small number of copies, it's look like negative. So we have to do a weak D test. So in weak D test, there are additional steps. We have to use here Combs reagent. So I have to use Combs reagent. and also there are incubation time. So after doing a weak test, if it's still negative, so that means this patient's donor is actually negative. But if it's become positive after a weekly test, that means this patient is positive. So it's positive even if it's from weak type. So it should be considered as positive. So in these two examples, we discuss the results, and in this example, we do extend phenotype. It's not mandatory. The mandatory is only the antigen, but sometimes in some cases we do extend phenotype, and we phenotyping the other antigens, these four important antigens. So in this video, we talk about RH system, the importance of the system. We talk about properties of the RH antibodies and discuss the antigens of the most important antigens in the system. Discuss the hemolytic transfusion reaction may happen as a result of incompatibility. We discuss also hemolytic disease of newborn, and finally we interpret the results together. So so thank you for watching this video, and don't forget to subscribe in the channel, and you can see previous videos. There are some more explanation about the details of antigen antibody reaction.